Welcome to the UCSF Sports Medicine Podcast, 6 to 8 weeks, Perspectives in Medicine. During our program, we continue to cover a variety of hot topics in the sports medicine world and more.
Welcome everyone to our UCSF Sports Medicine Podcast, 6 to 8 weeks, Perspectives on Sports Medicine with myself, Dr. Nirav Pandya, Dr. Brian Feeley, and Dr. Drew Lansdown. Today, as we enter the holiday season, we're going to be talking about something that's probably on the minds of a lot of people as they see an orthopedic surgeon or a sports medicine specialist. It is what exactly is going on in terms of ordering imaging, what does various imaging modalities indicate, and why do we order it? So obviously a topic that a lot of people have questions about. So we'll go ahead and get started. And Brian, you want to take us off on the first scenario or question?
Yeah, definitely. That was on my holiday list of things I wanted.
Nothing says holidays like medical imaging.
Yeah. I was going to go with mediocre quarterback play or how old is Aaron Rodgers really? But sure. So I think the first thing, if we just run the list of common imaging, we can get x-rays, we can get MRI, we can get CT scan, and we can get ultrasound. And for a lot of patients, the x-rays seem cheap. CT scans, at least for musculoskeletal health, are relatively esoteric. We don't use them a ton. And everybody wants an MRI, and ultrasounds on pretty rare. So I thought it would be worthwhile going through the advantages and disadvantages of each and talk about why x-rays are so important, what we actually use an MRI for, what you should anticipate for some of these studies. And then hopefully that answers a lot of the questions patients and other people have. So I guess the first question, Drew, is what do you think about when you get an x-ray? Should everybody get one? Do you only get it to look at certain things? What are its main advantages?
We'll get regular x-rays on most of our patients coming in to see us in the office. And I think for most, knee, shoulder, hip, hand, foot, these orthopedic complaints, when we're evaluating them, the x-ray really contributes to, making that diagnosis, figuring out what to do. The x-ray gives the best picture of the bone structure. It's quick to get, it's easy, and then it helps rule out a number of different things, like right from the bat. So, especially in the setting of trauma, like, is there a broken bone? Is there something that's not aligned right? If it's a more chronic condition, then we're looking for degenerative changes like arthritis. There's a number of signs on the x-rays that will, indicate that that joint is showing evidence of breakdown, and that could be contributing to the person's symptoms. Or even if it's not driving the symptoms, that it may influence the treatment plan that we're able to, to offer. And there are some times where the x-ray won't add a lot, but I would say for 95, 98% of the complaints that we see, it really helps, complete the evaluation and make sure that you're not missing things, looking at everything, and, getting that best plan together to figure out what to do.
So I thought I'd go through a couple of scenarios and we talk about whether or not an x-ray is actually beneficial. So let's say, Nirav, you have somebody that comes in, they're 15, they heard a pop while playing basketball, they had some swelling. Why do you get an x-ray in that situation?
Well, I think the first thing you always want to look at, even though everyone wants to jump to an MRI, is something broken, right? Even though we live in this world of sports injuries, a lot of times when injuries will happen, particularly in younger kids, things can break. So they could have an injury around their growth plate. They can sometimes pull a piece of bone off, or there could be issues, kind of just how the morphology of the bone is. So I think it's always important to get an x-ray first to rule those things out. I also think number two, in my practice, when kids are still growing, you want to get a sense of how much growth do they have remaining. That impacts our treatment as well too. And also we, even though MRI does show bone, x-ray does give a little bit more sense of the morphology of the bone. It's a quick study, you can get some information. So I really think it's about the information gathering. And the other thing that I think that patients also have to understand is that for a lot of times we do go on to get an MRI, but a lot of times insurance companies will also require us to get an x-ray as well too. So part of it is the information we get, part of it is making sure we get all the studies that are necessary to get that approved in a quick way through the insurance company.
Yeah, I had a kid recently that I was covering a football game. On the other sideline, they told me it sounded like an ACL in the game. I went over there and he was in a lot more pain than I would have anticipated from the ACL, enough that I couldn't even really get a good exam. And it turned out he had a distal third femur fracture. And the reality is the first thing that they do when they get to the emergency room, they get x-rays. The first thing that an athlete gets, if you're a professional athlete, they have x-rays in the stadiums. They have already gotten the x-ray. And the only reason why the first report is so-and-so got an MRI is because it's not exciting to say, oh, so-and-so got a negative x-ray right at the time of injury, and therefore they went on to get an MRI. So especially for acute traumatic injuries like an ACL, we can see what else is injured. If it really is an ACL tear, I mean, most of the time a pop with swelling going to be an ACL tear, but also it, like both of you said, it helps us plan because you see the morphology better. So there are things that we can pick up on x-ray much better than MRI that help us plan exactly what type of surgery we would want to do. Now, what about for shoulder instability, Nirav? Why do we get x-rays if we know that we can only see a labral tear, for instance? We talked about labral tears in the last podcast that didn't get eaten up by the internet. Why do we get x-rays if we know we're going to get an MRI to look at a labral tear?
Well, I think sometimes we can think that it's actually, just like you mentioned with the distal femur fracture, we'll think it's actually a shoulder dislocation, but you could have broken something. Patients, I think especially with the shoulder, because the knee, it's a little bit more, it's easier to describe, oh, my knee went this way, I felt this. In the shoulder, when you feel impact, particularly if you're like a football player, lacrosse player, you have pads on, you can say maybe the shoulder felt like it's out, but actually you could have broken your clavicle, you could have dislocated your AC joint. I mean, there's so many different things that could go on. So I think number one, you want to make sure you didn't break something, as we talked about other things. In addition, it's important to see like what actually is going on with the bone as well too. So if someone has a shoulder instability event, one of the things we're looking for is there an injury to the bone, whether that's on the socket, your glenoid, or on the humerus. So there's lots of different types of information I get, but I think more so in the shoulder than in the knee. I think it's also making sure that the shoulder dislocation is actually what happened, as opposed to there being some other injury that you might miss on an MRI, particularly if the injury is a little bit more kind of closer to your chest, as opposed to further out. You might have some sort of weird fracture that an MRI might not check, might not be able to see, or you want to get to know that a little bit quicker than if you're waiting 2 weeks for an MRI and suddenly you're walking around with a broken bone. So I think it's important to get that imaging.
Okay, Drew, what about rotator cuff problems? Entirely a soft tissue injury. Why do we get x-rays?
With the rotator cuff, whenever there's especially more chronic changes, we'll start to see compensatory changes at the joint. Like you see these specific patterns of the joint breaking down or the alignment of the shoulder being off. And then when we're, planning out treatment for rotator cuff injuries, if we see some of those findings on x-ray, then we know that the right treatment is not going to be repairing the rotator cuff. It's going to be like the surgery would be like replacing the joint instead. So it'll really make a big difference. And some of those things, like you can see that it's torn on the MRI, but you can't tell that alignment and some of those degenerative changes as readily on the MRI. Like they're there if you look, but the X-ray is just that two-dimensional projection, which is a little simpler. And so I think it often picks it up a lot better. And then the other thing is with an acute injury where we think, hey, it seems like their rotator cuff might be torn, like they can't raise their arm up, things like that. They could actually have a break. Like the rotator cuff attaches at the greater tuberosity, that piece of bone can break off. And if we just get the MRI, like Nirav said, we might be waiting for a while. Sometimes it's also harder to see the bony injury on the MRI. And then we could know right away in the office, okay, this is the bone broke off. Like we've got a plan to fix that. Maybe an MRI isn't even needed to look at the tendon because this is just a bony injury instead. So both like acute and chronic, it'll make a big difference.
Yeah, and I think in terms of planning, one of the things that's important with getting that x-ray for a rotator cuff problem is that if you have some early arthritis, your outcome's not going to be as good. And we want to tell the patient that. I'm sure a patient wants to know that. So jumping to MRI, because I think that is, by and large, it's probably our favorite thing to look at. And it's definitely the thing that gets the most widespread press, at least in sports medicine. What is the cost, Nirav, of an MRI compared to an X-ray?
That's a good question. I don't know. No, actually, no. So it's I don't know the exact cost, but MRI is several fold. higher based on your insurance, kind of where you get it done, whether it's in the hospital, whether it's as an outpatient, but it definitely is a much more expensive test. I would say 6 to 7 times more expensive. Both because of the technology, both also you think about for time. So like if you get an X-ray, that's about 2 minutes an X-ray, an X-ray machine. MRI can sometimes be 30 to 45 minutes, and sometimes even longer if you're getting a more complicated test. So the cost is definitely significantly higher, but the degree of detail that you're getting and also the amount of resources that are needed to do the test are significantly higher. So that's the reason why the cost is higher.
Yeah. So Drew, I'm going to go back to that first patient. You have somebody who's 15, they heard a pop, you got an X-ray, didn't show anything, they have a swollen knee. Do you need to wait till the swelling goes down to get an MRI?
No.
Why not?
So the MRI, it will show fluid, but sometimes that actually helps our interpretation of what's injured. But there's nothing really that will get in the way of that imaging. We can see everything right away, and no need to wait. And sometimes, so the fluid gives a signal in the MRI, and then that appearance next to normal tissue can help highlight, what is torn. But it doesn't mean that you have to get it like right then and there, but there's no reason to wait for sure.
All right. So yeah, I think it must have been old information because I get that not as much as I did a couple years ago, but I definitely get that like, well, should I wait till the swelling goes down so you can see what you need to see? And absolutely not, especially for shoulders where there's a little bit of blood in the joint after a dislocation event. It can be really nice to highlight subtle injuries. All right. So Nirav, when you get somebody in your clinic, you feel their knee, it's obvious it's an ACL, everything else feels okay. Why bother getting an MRI? Why not just jump straight to surgery?
Well, I think part of it is kind of collecting more information. I mean, even though our physical exam is usually pretty accurate, you can sometimes miss certain injuries or be kind of, you don't want to have someone, go to surgery and then say like, oops, I kind of missed it. So I think it's important to get a little bit more information if that's actually the diagnosis. I think number two, in the pediatric population, a lot of times it's actually hard to examine them because, or even in the adult population, they're kind of guarding a little bit. They're not, you don't get a full exam. They may be, several weeks out from the injury. But I think most importantly, you're collecting information in terms of other injuries that might be there. You want to look at their meniscus. You want to look at their cartilage. You want to see what other ligaments are there that you may not necessarily be able to pick up on physical exam. So you want to be prepared to be able to fix everything and counsel patients before you get into surgery, as opposed to the, let's look in and kind of see what's there. I think it just helps to get that more information so we're prepared and understand more about what we need to do to have them have the optimal outcome.
Yeah, I think it's important. It's not that we wouldn't see these things at the time of surgery, but it changes your post-op management. So for instance, for certain types of meniscus tears, if we end up doing a repair, you're going to be on crutches for 6 weeks versus with an ACL, it may only be a week or two. And that's going to change how somebody may change when they have surgery based on how much time they have off of work or when people are going to be around to help. So I think that sort of surgical planning is really important. So Drew, why don't we get an MRI in the setting of arthritis? X-ray show moderate to advanced arthritis, but feels like it might be a meniscus tear. Why not just get an MRI to look around?
I think the biggest thing is that most of the time it won't change what we're able to do and what we're able to offer. And when there is that more advanced arthritis that you see on X-ray, our arthroscopic treatments are pretty limited. Like it's not like, oh, we can go clean up the arthritis or we can go reverse this if we see this or that on MRI. It's really like the surgical treatment's a joint replacement, and we don't have the tools to intervene on really anything we'll see on the MRI. Like it's just not actionable information, so it doesn't add to anything. It just wastes some time and doesn't really change that treatment plan.
Yeah, I think one of the tough things is this idea that an MRI is helpful just for a look around and staging of things. And it's challenging because now they even have whole body MRIs, which will show non-specific changes that you don't really know what to do with except for get another MRI and look a little bit more closely into that area. But that area may not have been symptomatic. I had a patient who has some knee problems, never had any shoulder problems, got a full body MRI, and it showed possible synovitis in the shoulder. Didn't hurt, but wanted to follow up for their shoulder with a more up-to-date, closer MRI of the shoulder. I said, probably don't need it. Got the MRI, and it showed mild synovitis in the shoulder. So that was out of pocket for the first MRI, but about $4,000 for the second. Shoulder is still asymptomatic. It's not going to change management. And I think the other thing that's tough with MRIs is that the report in particular doesn't differentiate between something that's clinically symptomatic and these are age-related changes. And Nirav doesn't have to deal with this as much, but our bodies degenerate in our 30s, 40s, 50s, and certainly 60s and 70s. And a lot of what the MRI shows is your shoulder's just getting a little bit older, and that's normal for your age. But a partial thickness tear of the rotator cuff in the supraspinatus to infraspinatus junction sounds horrid until you realize that can be a normal finding over the age of 45.
Yeah, my body's not degenerating, Brian. That's why I don't have to deal with it.
Right. Right. So jumping to CT scans, which we don't use as much in sports medicine, but we do use in trauma and certainly after other surgeries. Nirav, when do you think about getting a CT scan?
I think, particularly with fractures, I think that whenever we're worried about, is there potentially some sort of fracture that we don't necessarily see on X-ray? MRI can sometimes be hard to look for subtle fractures because there's so much inflammation. So looking for little subtle fracture lines is difficult. I also think if we're looking at doing some sort of surgery where three-dimensional anatomy is really important. So if we're going to be cutting a bone or we're looking at doing some sort of reconstruction of the foot, I think the CT scan really helps us give us that information. Whereas MRI is really good for soft tissue. Now, obviously you can kind of get some soft tissue data on a CT scan and some bony information on MRI, but I think a CT scan is really good for giving us the measurements we need to do to understand things three-dimensionally. So we're doing some type of surgery with someone who has patellar instability. We want to get a more three-dimensional look at kind of how their thigh bone is or kind of how their kind of their patella, the morphology of it is. I think that's really important. But I think the vast majority of us use it for more fracture work, particularly looking at, does a fracture that you see on X-ray go somewhere or look worse than we actually think on X-ray, which helps us plan treatment.
And Drew, what about you? Around the shoulder, when do you think a CT scan is more helpful than an MRI, or what do you like to use it for?
Yeah, there's a couple different conditions. One is shoulder instability. When people dislocate more and more times, they actually start to wear away the bone, especially at the glenoid, the shoulder socket. And it can be hard to pick up, especially on X-ray. And then MRI is also often not as good unless you have like specialized sequences that let you look at it three-dimensionally. But a CT scan lets you see kind of exactly what that bone looks like, how much bone is potentially missing. And then that's one that, if there's a lot of bone missing, then we do a surgery to restore bone rather than just fixing the labrum. And the CT, I think, is really important in those people that have dislocated a bunch of times and are at risk for that bone loss. And then the other one at the shoulder that I think has a lot of value is with shoulder arthritis and shoulder replacements. I'll pretty routinely get a CT scan to, again, look at the shoulder socket and then be able to plan out the replacement. There's now like pretty good software where you can, visualize where implants will sit, how they'll make up for what's lost, where they'll, potentially give you the best range of motion, things like that. And you can really plan out a lot ahead of time. That I think saves some decision making in the operating room, and then may give us better outcomes. That's still debatable, but it at least lets you plan it out and kind of know what to anticipate, what problems you might run into, and you don't get that same bony information just from most MRI scans. So those conditions is pretty helpful.
I have a stupid question for you, Drew.
Yeah.
You're an imaging expert. Why don't we get the same bone quality with an MRI that we do as a CT scan?
So you can. With MRI, it's just you're always looking at that different signal from different tissues and based on the composition of the tissue, and there are sequences that can distinguish between bone and soft tissue really well, and then part of it is the resolution. So if you think back to like old school low definition TV versus a current like 4K model, like the grainy pixelated appearance versus like perfectly clear, like that, like a low resolution scan versus high. And then the MRIs and CT are done in slices. But if you're going to look at something three-dimensionally, if it's like a really bad picture, and then you're trying to put together, a 3D model, and then you're counting on, picking up like a 1 millimeter difference, you just don't have the resolution to do it. And then sometimes with the MRI, it's taken somebody like physically outlining where the bone is, which is just like super labor intensive and not really practical. But there are some sequences that we can get that show the bone really well. It almost looks like a CT scan, but then you can automatically pick out the bone. But most of the time when you're getting a clinical MRI, you're not getting that sequence because it just adds another 5-10 minutes. And most of the time it's not really necessary or adding value.
All right, last thing, ultrasound. Really quickly, Nirav, when do you think ultrasound is helpful? Do you use it in your practice? How do you see it fitting in?
I think for a lot of patients, particularly when you're looking at inflammation or looking at kind of tendon injury or muscle injury, I think that if you yourself are very good at ultrasound, or we have someone in your practice that's really good with ultrasound, it can be a quick way to get information as opposed to having to wait for, an MRI or things like that. It can be done in the office setting. So, looking to see, is there, tendon rupture? Is there inflammation around a tendon? Is there a rotator cuff injury? I think the ultrasound, particularly in someone's hands, is very skilled, can be very useful. I think it also helps if you're trying to get injections into certain places. It can kind of confirm that you're in there as well too. And then from a pediatric standpoint, we also use it for a lot of other conditions, such as people have dysplasia of the hip when they're babies. So I think it's a great quick imaging modality that does not have radiation, very low risk associated with it. So I think if you're good with it and you're in the clinic, it's a way to get diagnoses or rule out things pretty quickly in the office setting.
Yeah, I think it's nothing that we have trained with, but we definitely have colleagues that use it at, I think, higher and higher fidelity, especially to make the office procedures work better. Well, hopefully that's helpful. I think hopefully people understand that what we use imaging for is to really use it to guide decision-making in clinic and decide surgical decision-making. So we're getting these things to really plan a surgery, plan the natural history of what's going to happen to your body. We don't just use it for a look-see. So thank you very much for joining us on 6 to 8 Weeks. Listen wherever you get your podcast, whether that's Spotify, YouTube, ham radio, wherever Nirav's going to listen when he travels to India. I guess I shouldn't say that because then people know you're not in your house, but I will do it. All right. Thanks.
Thanks for listening to the UCSF Sports Medicine Podcast, 6 to 8 Weeks, Perspectives in Medicine. What do you think of this topic? Connect with us now. In addition to finding our contact form, you'll also find our social media links and our entire 6 to 8 Weeks episode archive. Help us grow our listenership by liking, subscribing, and sharing everywhere. We're eager to hear from you, and we'll be sending you more great thought-provoking content in less than 6 to 8 weeks.